Welcome back to Psychiatry Boot Camp. I am so excited about this episode. It's a longer one, but I hope you know that I have so much respect for your time, and I would not waste a minute of it. Anyone who has ever rotated on a Consult-Liaison psychiatry service will not be surprised to hear that the first psychiatric horse that we are covering is delirium. This episode turned out to be an absolute masterclass, perhaps something more akin to wizardry than medicine, and as you will hear, Dr. Oldham is a true expert's expert. He is also someone who speaks remarkably passionately about his work, and I think his sense of purpose and heartfelt interest in sharing an evidence-based and nuanced understanding of delirium comes across really clearly. We're going to discuss how to conceptualize delirium, how to go about evaluating a patient for delirium, prevention strategies, and management approaches, including what's most evidence-based right now, as well as exciting new directions for future translational research. Getting right into it. Welcome to Psychiatry Boot Camp, Dr. Mark Oldham, and I will ask you to introduce yourself to our audience.
Sure. Thank you so much. My name is Mark Oldham. I'm a consult psychiatrist at the University of Rochester Medical Center. I'm currently an assistant professor, but imminently to be associate professor of psychiatry. I'm passionate about delirium. And as pertains to our conversation today, I'm the president-elect of the American Delirium Society. So yeah, delirium is definitely something I think a lot about and something I'm excited to talk about today.
Wonderful. Well, congratulations on your promotion, and thanks for making the time for this. So, when I was kind of researching this topic, thinking about expert guests, I got to tell you, your name came up everywhere. And then I looked you up on Twitter, and it's very clear to me that delirium is a very special topic to you. So, I'm interested. How did it come to be that you decided to focus so deeply on delirium?
Yeah, no, I like the question. So my name, I guess, was coming up because I just keep talking about it and don't shut up. No, I think delirium represents in many ways why I went into consultation liaison psychiatry. So I went to med school because I wanted to be a psychiatrist, and I knew that to become a psychiatrist, you had to go to med school. I knew very little about medicine. At the time, I'd never really met other physicians, no physicians in my family. And I said, well, I need to go to med school. And it was really just, I was fascinated by the interaction between the brain, the mind, the experience. And I thought psychiatry offered all of that in a very kind of, a very clinically based context. And I really appreciated that vision of psychiatry. And then when I got into medical school, the very first rotation that I did was in CL psychiatry. And it clicked. And I said, okay, this is what I want to do. And then as I, was working in the hospital, even I think the first and second year of med school, saw patients with delirium. And it was so compelling to me to think that something in the body is happening. And in this dynamic relationship between the brain, the mind, the body, um, the medical condition could mimic essentially any psychiatric symptom that we see in any of the many psychiatric conditions that we recognize in the DSM and beyond. And it was something that was compelling. And then, kind of as I began reading about it, I found that I was late to the party because Zbigniew Lepowski had written a beautiful treatise in the introduction to his first of two monographs on delirium, where he explored this idea that delirium is an experiment of nature that teaches everyone about these relationships. Delirium is in itself a prototype to understanding many of the ways that brain networks relate relate to other physiological processes throughout the body and lead to changes, alterations in sleep wake, in consciousness, in mood, and perceptions, and the like. So, yeah, I just find it endlessly fascinating as a model, and certainly from a clinical perspective, very much drawn to help people who are cognitively vulnerable, those at risk for delirium, and those with delirium, and then kind of finally improving the outcomes of delirium itself.
So, it sounds like you're saying you see delirium as almost a prototype of what it means to have a psychiatric illness.
Yeah, yes, in a way, yes. I don't know if I would call it strictly a psychiatric condition, and I don't know that I would call it strictly a medical condition. It's kind of both and it's kind of neither nor. And when we are kind of on this kind of razor's edge of what is psychiatric and what is medical, our language fails us. So, historically, the subspecialty that I'm in was called psychosomatic medicine, and that term means something different internationally as well, outside of the U.S. as I'm understanding and finding and kind of reading more about this. But but essentially, you have the mind, the body, and we know that the two are in dynamic relationship. And so delirium kind of it illustrates, I'll say it's illustrative of this relationship, and it spans the two in a compelling way, in a way that I feel like is undeniable. And there's something about that, again, that I find compelling and that can teach us quite a bit about perhaps other mental health conditions and the way that the mind and the body relate.
Perfect. And you just kind of got to this. You called it a razor's edge. So I'd love to know if delirium is a medical issue or a psychiatric issue, but it sounds like you're telling me that answer is not going to be so simple.
No, it's not, unfortunately. No, I mean, I think it sits right on the edge. Even when you look, for instance, at the way that the legal considerations might bear upon medical care in the hospital. There's public health law that might address medical sides of things, and you have kind of mental hygiene laws in different statutes that come to bear on patient care and protecting patients and informing care. Very often the two are kind of in their own silos. And a person with delirium, when you look at where does a person with delirium fit, there's enough there that kind of pulls the person away from the protections that medical kind of public health law would provide. And there's enough medical there that pulls them away from, actually falling under mental hygiene laws to protect people when they're making decisions that might otherwise be disastrous or dangerous to themselves or to others. And so there's enough there to kind of to push it out nicely out of the purview of one or the other, but there's enough there that it kind of sits squarely in both. So I think this is a condition that defies a clean categorization in that regard.
Okay, so here's another question that comes up a lot, I think, throughout medical training. We mentioned kind of the medical side, the psychiatric side. Obviously, neurology is very involved in these cases often as well. And I'm interested, what is the formal difference between encephalopathy and delirium?
So I'm going to have to point to a recent position paper. So Aryan Sluter and colleagues published a paper in 2020, and I really like this paper. This has been somewhat of an inspiration to me the last few years, really kind of working this out. What are the natural conclusions of this position paper? But essentially, 10 different organizations, 10 medical organizations came together and kind of put a stake in the ground to define encephalopathy and delirium and kind of the delirium spectrum. And they describe encephalopathy or acute encephalopathy, I should say. And in Europe, I think they call it encephalopathy. I
Yeah.
don't hold that
Yeah.
against them. But so encephalopathy is the acute encephalopathy is the pathobiological brain process that occurs over the course of 4 weeks or less that presents clinically as the clinical spectrum ranging from subsyndromal delirium all the way to coma. And so the clinical phenotype that we see at the bedside is definable, it is operationalizable, and it is reliably detected. And we know this because we can identify specific cognitive, behavioral, and other features that are allowing us to provide a diagnosis. So, subsyndromal delirium is a condition that is somewhere intermediate between kind of healthy and delirium, unimpaired and delirium, that represents some, but not all, of the diagnostic criteria for delirium. Delirium then is defined, be it in the DSM-5-TR, the ICD-11, something like that. It has a very clear kind of clinical phenotype, and then obviously coma, moving into coma, kind of unresponsiveness. But pathobiology, specifically the pathobiology that presents at the clinical state is the acute encephalopathy. So the word encephalopathy implies, but does not kind of directly define what the clinical phenotype is. Because it can present as a spectrum, right? So we know that it presents with air quotes confusion, but it can range pretty widely from subsyndromal delirium all the way to coma.
Gotcha. So you may have a patient who could be clinically called encephalopathic, who is not necessarily meeting strict criteria for delirium. Is that right?
Absolutely, yes. So we can kind of work the arrow both ways. So as you're saying, a person can have an encephalopathy, an acute encephalopathy, but not meet criteria for delirium. That is, their clinical state is like, let's say, less severe than delirium, so they have subsyndromal delirium, or let's say they are essentially unresponsive, and so now they have coma or near coma. They have encephalopathy, but they don't meet criteria for delirium because the clinical state is not meeting criteria for delirium. On the other hand, a person who has the clinical diagnosis of delirium according to the DSM or ICD, by definition, has an underlying encephalopathy. It's simply that we have kind of drawn lines in the sand, as it were, around the ground beneath delirium, the clinical phenotype, that is encephalopathy.
That is crystal clear. And we are in the business of drawing lines in the sand, I think, in psychiatry. So, next thing, how do we diagnose delirium? That is, like, how do we define it and how do we diagnose it in our patients?
Sure. So, um, referring again to the DSM-5 TR, so delirium is diagnosed based on an acute change in mental status, and change that is change from baseline. So this is not the individual's known cognitive personality baseline, what have you. It presents with an acute change or a disturbance in attention, a disturbance in awareness, and at least one other demonstrable cognitive deficit or a deficit in a specific cognitive domain, which could be orientation, memory, visuospatial performance, what have you. So, I mean, essentially, those are all A's: an acute change in a disturbance in attention, awareness, and another, which I hate that, that's another A, but another or at least one cognitive domain. And then in the DSM, we have two other considerations. One is rule outs. So it cannot be due to essentially dementia or kind of an evolving dementia. And then the final one is one has to attribute the clinical phenotype that you're seeing to the direct physiological effects of an underlying condition. So whatever the proximal precipitant is, right? So and that's important in a sense because there are some other clinical conditions in psychiatry that can look very much like delirium, but not be delirium. So some presentations of catatonia can be somewhat challenging to differentiate from delirium. Most of them are not, but some of them can look a little it can be confusing. Some individuals who have disorganized schizophrenia, disorganized psychosis, kind of broadly, there are a few dissociative states that can be very challenging, like Ganser syndrome or other states like that, functional cognitive impairment that can look like it. I mean, so barring those conditions, there needs to be a clinical presumption or attribution to an underlying physiological cause.
Do we need to actually know what that precipitant is in order to make the formal diagnosis of delirium? Is that what you're saying?
So, so there are ways of. I mean, according to the DSM, you can
Yeah.
diagnose it without. So it's kind of
Okay.
it's implied, and the clinical phenotype so well that there's no question. And if you
Right.
ever really wanted to test it, you could do an EEG, and you could demonstrate the classic kind of slowing on EEG. So you don't need to have identified it. One can have it as a presumption based on kind of the overall convergence of all the other clinical factors. And most of the time we find the cause. Some of the times we don't, and that's really kind of frustrating and stymieing for us clinically as clinicians, but also, and even more so, the patient and their loved ones, right? So we'd love to be able to hang our hat on that, but you can diagnose delirium presumptively without the known cause.
Perfect. So our sort of intended audience for this is really learners at the bedside. Are there any specific clues from the mental status exam or like when you're evaluating a patient in the hospital, specific bedside tests that you like to do when you're assessing the patient and considering a diagnosis of delirium?
Sure. So usually, but not always, it's obvious. Usually, delirium is fairly clear and clear cut. I think really when it comes to the kind of the more challenging differentials, kind of the some of the conditions that I've already mentioned, so disorganized psychosis, all add into that list. Mania, this kind of idea of delirious mania, and so forth. I think those might be where some of the additional tests might be really helpful. But I mean, yeah, I would always do clinically the hallmark finding of delirium is a disturbance in attention. And a disturbance in attention can present in a number of different ways. If a person cannot even engage in the conversation, like they cannot even, let's say, make eye contact and engage in the conversation because they're incapable of orienting to a kind of an environmental stimulus, namely me as the interviewer, the clinician, then that itself indicates inattention. Um, Next, a person, so that's kind of focusing attention or directing attention. Next is the ability to sustain attention. And so we test sustained attention by way of bedside tests. So things in the ICU, like the Vigilance A task. So that's kind of saying, squeeze my hand when you hear the letter A. And then kind of doing Casablanca or another sequence of letters, and they should squeeze when you say the letter A, but not on other letters. There are other tests of attention like reverse digit span, so giving sequences of numbers um, uh, uh, and having them repeat them in backward order, giving the days of the week backward, the months of the year backward. Each of these requires taking a chunk of information and focusing on it long enough to provide it backward or sustain attention on the task long enough to provide the appropriate or correct response. And then the third way, so one would be focus or direct attention. The second is sustaining attention. And the third is being able to switch attention. And so if you're unable to shift or switch attention, we call that perseveration. So if a person kind of, if you say, where are you? And they say the hospital, and you say, what year is it? And they say the hospital. And they say, give me your name. And they say the hospital. That's perseveration. And so they're unable to update their attention on a new conceptual stimulus, this new prompt that you're giving them. And so that would be evidence of inattention because they're unable to shift attention. So I would say my clinical tests really focus on attention. If they have impaired attention, usually one can almost infer that they're going to have deficits in higher order cognition, like the registration of information for memory or the recall of that information for memory. Or if you're not oriented to the environment appropriately, then you're almost always going to be disoriented to some extent, right? So these higher level deficits are predicated on these lower kind of core cognitive abilities of paying attention and simply having a what we call a clear sensorium, being able to interpret the world around you in clear fashion.
So those are some ways that you would get that very fundamental foundational criterion of inattention in terms of diagnosing the full syndrome of the clinical entity that we call delirium. Any standardized instruments that you'd recommend we consider reaching for?
So, I mean, as a physician, I don't know that I personally tend to use a lot of tests to augment my own clinical care. Although sometimes I do, but usually I don't. Usually it's kind of a clinically invested, kind of rolling with it kind of evaluation because I think clinical work is very Bayesian, right? So we start with our priors and then the information in front of us, then it changes the way that we engage with the patient. And so we might move in this direction if we see this, or we might move in another direction if we see something different. So clinical care, I think, is a little different, I think, in our kind of logic and thinking about, again, likelihood ratios and applying those to our priors to posteriors and so forth. Um, but for let's say for research or for those who might not be as familiar with the mental status exam or neuropsychological testing, there are a number of tests out there that are standardized. So a few things about that. One, the confusion assessment method, or CAM, I think is very often the most commonly kind of referenced, the most commonly kind of known. There's great awareness of that as a delirium screen. And so the CAM, though, what needs to be appreciated is when we say the diagnostic CAM or the short CAM, it's 4 criteria. So acute change or fluctuation, attentional impairment, we'll say a change in arousal level, and then fourth, a kind of gross cognitive impairment or cognitive, broadly, kind of thought disorganization. And you have to have 1 plus 2 plus either of the others, the change in arousal or thought disorganization. So that's kind of the diagnostic algorithm. But what should be appreciated when using the CAM is that reliable use of the CAM requires cognitive assessment, dedicated cognitive assessment. It's not something that one can just kind of say, oh, I just talked to the patient. Now I'm going to score these 4 elements. When you look at the literature, how it's validated, it's a great tool, but it should be used in the way that it was validated. So there was originally kind of a long form CAM, which is a kind of a longer interview, kind of a semi-structured interview to ascertain the different parts of the CAM. The long form CAM actually has 10 elements, but the 4 of them are the diagnostic piece. Then it was operationalized as the 3-minute diagnostic interview for the CAM, or the 3D CAM. I personally like that one in general medical patients. It's pretty efficient. It's intuitive. There's a structured section at the top of very specific kind of orientation and attention type questions, a range of observational items, and then based on your answers to these, again, it's a standardized way of administering and scoring the CAM. So the 3D CAM I like, and then there are 2 other forms of the CAM that are commonly used. One is the B CAM, or the brief CAM. This was originally used and developed for the emergency room for kind of a more rapid assessment for delirium. And that's a standardized way of scoring the CAM. And then finally, there's the CAM ICU, or the CAM for the intensive care unit. And then it also has a worksheet that you follow. And then it's actually, you start with arousal level. And so if you have a RASS, or Richmond Agitation Sedation Scale score of -4 or -5, you can't score it, so it's an unscorable. And then it you can kind of avoid having to do it. So it kind of has that skip criterion, if you will, for assessing someone using it. So those are 3 ways of standardizing the CAM. There are a few other ones that are used clinically that I think are important to at least consider. One is the 4AT, or the 4A's test. This was developed, I believe, originally in Scotland, and has really seen a great deal of usage internationally. I think increasingly in the U.S. More recently, I've heard of some institutions using this, but it heavily emphasizes the role of a change in mentation and also a change in arousal. If either of those is present, it essentially is positive. So I think it ends up being a lot more sensitive clinically in the course of routine clinical care. Again, because those are 2 things that are pretty obvious, and you already get a presumptively positive 4AT with either of those without the use of cognitive testing. But if inattention requires on the CAM, in the diagnostic algorithm, inattention to be assessed, and you don't assess it, then it's easy to skip over and say, oh, they're attentive because they said yes or no to me when I was giving medications. And then the final one I might mention is the NuDesk. It's also, that's a nursing-based screen, and it's kind of a look back over the course of a nursing shift. And it basically asks questions about whether the person was hyperactive, if they were hypoactive, if they were having psychotic symptoms or perceptual disturbances, things like that. And again, it ends up being a little bit more sensitive because it's a look back and it really kind of takes a global approach to overall mentation and behavior over the course of that episode, that nursing shift.
Very, very thorough for us. And all of these instruments that you just mentioned, I'm sure, are very easily findable online for our learners. One of the big points you mentioned was taking time to formally assess the various domains of cognition. Um, Throughout training, this is something that really kind of shocked me at first was you can have a seemingly normal, superficial interaction with someone, and then you ask them to draw a clock. And sometimes it's like, oh my goodness, if you're not actually doing the test, um, our gestalt is not necessarily as good as we think it is sometimes. It sounds like for our learners too, you might recommend, like, as you're first learning how to assess delirium, it might be helpful to get like a 3D cam, take it to the bedside, formally work through it. Certainly a useful exercise to go through these instruments to give you a better understanding of delirium. But realistically, for a more experienced practitioner who is using the mental status exam several times a day, often you don't actually need to go so far as to use a formal screening instrument. Is that a fair summary?
Totally. I completely agree. Yes.
Okay. So you mentioned screening for delirium in the ED, which makes me wonder, why is it so important that we recognize delirium?
Many reasons. Delirium is important. I guess one thing I'll say, even before that, kind of to follow up on your prior point was, open-ended questions matter. So in clinical settings, it's very often that when we engage with patients, there are many different ways of asking a question. You can ask closed-ended questions, open-ended questions, and variably open questions. So for instance, a closed question would be, how many hours did you sleep last night? That's a very specific question, right? They only can give like a number of hours, presumably. I mean, if you're answering the question literally, they give a number. Um, did you sleep okay last night is a variably open question because the right answer to that literally is yes, no, maybe, kind of. But what you're usually implying is you want to know how they slept. So an open-ended question would be, how did you sleep last night? Or perhaps framing it more as an instruction, tell me about your sleep last night. Something like that. So when we as clinicians use closed-ended questions, we very often can overlook and it can help to belie some of the cognitive impairment that might be present, and there is the patina of clear-mindedness or clarity of thinking, when in all reality, that's not the case, and we've actually kind of injected our own sense of clarity on the situation. We've led them to answers. They've given the answers that we kind of set them up to give. We haven't given them much of an so again, so I think that's important to consider in the way that we engage. And if a person's always giving short answers, I should say, it's important to even kind of go back and kind of review the kinds of questions we're asking and maybe now open it up if we really do need a little bit better narrative from the patient. But getting to your question that you'd asked here is kind of why is it important to diagnose delirium? I think the chief reason it's important to diagnose delirium is if a person has delirium, there is a cause. And if you don't diagnose delirium, then I mean, then you essentially ignore the kind of flashing red light and sirens that are going off in the patient's brain that's trying to tell everyone around them, hey, look, something is not right. So again, delirium is at heart indexing an underlying medical, surgical, neurological condition that is affecting the brain. It is so severe that it has caused the person no longer to be able to think clearly, coherently, cogently, what have you. So the main reason that it's important to diagnose delirium is to find the underlying cause. But then there are other reasons too. So beyond that, delirium has horrible outcomes. We know people who have delirium end up very often having either new cognitive impairment after the episode of care. Some individuals with delirium do not get back to their previous level of functioning. So it indicates that there was some neuropathology that progressed during the process of that delirium, in the midst of that delirium. Some individuals have accelerated cognitive decline after delirium, and recently the 6-year trajectory outcomes of the SAGES study were just published earlier this year, 2023, and found that people with delirium after a major surgery had a 40% greater cognitive decline at 6 years relative to those without postoperative
Wow.
delirium. And so it's important because it also tells us something prognostically. And then we can obviously we don't want to I don't mention this last because it is least important, but the patient's experience, right? So someone who has delirium is not living their best life. I've never met the person with delirium who was, and I don't anticipate ever meeting the person with delirium who is living their best life. They're not going out, to the park with their friends or their family. They're not going, they're not at their own kitchen table. They're not watching their own evening shows in their own home, right? They're not spending time, doing all the things that they love, whatever hobbies, sports, whatever their interests. So it's important because, we really need to pay attention to the distress that patients are having, providing education for families, and really making sure that they have the kind of supportive environment for recovery and safe recovery that we can provide.
Brilliant. So definitely important so that we know to do a more in-depth workup to look for the culprit of what's causing delirium for prognostic reasons. Really because I don't know, to heal the person, to help improve their quality of life, kind of like what we are here to do. Psychiatry Boot Camp is brought to you by Simple Practice. Are you thinking about starting your own practice, but you're too daunted by the business and logistics? Or maybe you have a practice, but you're spending so much time on scheduling, record keeping, and billing that it's burning you out and slowing you down? Simple Practice is the solution for you. Simple Practice is an all-in-one EHR designed to help practitioners thrive. From admin work to clinical care, Simple Practice has a suite of tools that work together to simplify practice management. This includes e-prescribing and PDMP checks integrated within the app, and a lab slip template that can be easily sent to patients within the portal. With Simple Practice, you can spend your time on what matters most. For an exclusive 7-day free trial and 70% off 4 months, visit simplepractice.com/bootcamp. That's simplepractice.com/bootcamp. Psychiatry Bootcamp is brought to you by Beat the Boards. I am so excited to have Beat the Boards as a partner because this is the question bank that I use to study for my own psychiatry board exam, and it made the exam a breeze. The Beat the Boards question style was so close to the style of questions on the real exam that I felt over-prepared during the test. Beat the Boards has courses in psychiatry and virtually every other area of medicine. Visit beattheboards.com to view the entire catalog and take advantage of Psychiatry Bootcamp's exclusive additional 10% savings by entering the word bootcamp in the referral line in the shopping cart. Again, unlock these additional savings with referral code BOOTCAMP. That's one word, no spaces, bootcamp. How dangerous is delirium? Or perhaps I should say, what makes delirium so dangerous?
Mm. So I guess I'm going to put this in a couple different categories. What makes it dangerous, let's say, just the symptoms of delirium. It's dangerous because I guess I'll use kind of a clinical scenario. So if someone came up to me or you on the street and wanted to stab us with a needle, we would fight back, right? So I would not just let somebody do that. I would respond. Now, if you're in the hospital and you have delirium and you don't recognize the people around you, and, ostensibly the people around you are trying to help you, but there's this person and you just told them you're at home, even though you're not. So you're disoriented to place and situation, and they're coming at you with a needle or trying to give you these pills that you've never taken before in your life. And they don't look familiar to you at all because when you go in the hospital, they're always looking different. They're formulations and they start new pills and stop old pills. Um, it's not unreasonable to think that a person with delirium who is not interpreting their environment correctly would react in unpredictable ways, be it impulsively, be it in kind of a defensive way, swatting at people. And so in that sense, it's dangerous because the person with delirium is not going to be making reasonable decisions, behavioral decisions, reactions to people, and engaging with their environment in an appropriate reality-based way. So that's one example, but somebody, in the hospital, they don't remember that they had surgery the other day on their hip and they try to get up because they think, hey, look, I should be able to get up. I need to go use the restroom. Not recognizing that they have a catheter and not recognizing that they're in a hospital bed and not remembering that they had a surgery. They get up and then, let's say, they're deconditioned, or maybe they're a little woozy, or they're a little lightheaded, or, they're in a cast and they just fall, right? So it can be dangerous to the individual because of the decisions that they make. But the other elements of danger, so that's kind of one bucket, like the experience of delirium contributing to the danger. The other way, I think, broadly, is the many things that cause delirium are themselves dangerous.
Huh.
And the people who develop delirium generally, but not always, have a certain degree of vulnerability cognitively, physiologically, in terms of frailty, to delirium. And so delirium is dangerous because, the person who has delirium has a very significant, very often severe medical condition that is, causing damage on its own. And then, of course, if you're not getting up for a little while, you become even more deconditioned. And if you're not eating as much because you don't have the actual kind of, initiative to eat, then you become, dehydrated, malnourished. You're not getting up and walking, so you get weaker. All of these things kind of, they compound one upon another and lead to worse outcomes.
Worse outcomes meaning much longer length of stay, meaning higher mortality risk,
All of
any
the above, all of the above, all of the above. Yeah. So, I mean, it's in some sense, and I say this in all sobriety, um, that one could pick essentially any outcome they wanted that's bad, and functionally and mental health wise, I feel like, and do a study and find that delirium is associated with it. Now, I mean, I'm being a little facetious in saying that anyone, but yes. So there are countless studies, scores and scores of studies and meta-analyses looking at in hospital and post-discharge outcomes. And delirium is pretty consistently associated with worse outcomes across the board. So thinking about in the hospital, greater risk of mortality in a number of contexts, longer ICU lengths of stay, longer intubation, just because let's say, the agitation or activation during extubation trials leads to a failed extubation trial, and then they've got to try it again the next day, right? Longer overall length of stay, other complications, hospital complications like falls and so forth. And then outside the hospital, it can be things like higher mortality, greater risk of cognitive impairment, higher risk of institutionalization, so discharge to a location other than home, or a higher level of care. So yeah, really across the board, delirium has just a range of really dire outcomes, unfortunately.
how common is delirium?
Too common. Too common. Yeah. So the statistics on this kind of vary depending on the population you look at. And that could be based on, if we look specifically at older adults versus kind of a broader population, kind of an all-comers population. But I think in general, it's usually a conservative estimate to say about a third of older adults who are medically or surgically hospitalized will develop delirium or have delirium at some point during their hospital stay.
Wow.
In critical care settings, again, the statistics vary quite widely, but it's not unreasonable to say that 50 to 70% of people will have had delirium at some point in their hospital stay, those who require ICU level of care. And then depending on the surgery we're talking about and the population, those numbers get lower in different contexts. But again, it is substantial, both in terms of the reason for presentation. So it's the thing that really brings someone to clinical care, as well as in the midst of care, as the acuity of illness kind of ramps up, delirium itself ends up happening with terrible regularity.
And that will not be surprising to anybody who works on a hospital consult service. I think that on the psychiatry consult service, this is a lot of what you do. It's the bread and butter in some ways of what you do. And you're talking a lot about how delirium is on the razor's edge between psychiatry and medicine, but really the underlying cause is medical. And that's what we're here to do, is to treat the underlying cause, to alleviate suffering. So why are we as psychiatry even really involved if the foundational problem is medical in nature?
That's a great question. I say that in sincerity because I have often asked myself that question because I felt almost a sense of kind of clinical nihilism at times. Because on the one hand, if I kind of start trying to tell my medical and surgical colleagues how to manage the very conditions that they're managing, then it can sound rather patronizing. And so you have to step very respectfully and diplomatically into those conversations. And then at the same time, we really lack, I'll say, disease modifying care. I mean, that I'm just using that as an analogy. We don't really have the delirium antidote as a whole. And there are a lot of reasons for that. I'm sure we'll get into treatment in just a moment. But yeah, I think a few reasons psychiatry ends up being involved are one, practically speaking, when somebody is, I'm going to use this as a broad term, altered, they're not acting like themselves, their personality is different. I think a lot of clinical teams are busy trying to save lives and treat patients, and they're not maybe as attuned to or don't have the time to do a more nuanced cognitive exam, mental status exam to really say, is this schizophrenia? Is this bipolar disorder or simply depression? Is it delirium? Is it something different? Help. So I think in some sense, the pragmatics of diagnostic clarification is often what might drive a psychiatrist to being involved as a consultant in the medical setting for a person with delirium. Another one is the idea, and this is kind of an idea that I'm kind of trying to pull from the dementia literature. We talk about the behavioral and psychological symptoms of dementia. Delirium has essentially, I'll say, a similar palette of neuropsychiatric disturbances. Now, they're a little different, a little bit more acute, and they can present a little differently. But I think by analogy, delirium has a range of neuropsychiatric disturbances. And it's the disturbances like hyperactivity, agitation, the paranoia, the irritability, leading to care non-adherence, combativeness, impulsivity, and just bizarre or odd experiences. All of those are intuitively psychiatric symptoms.
Totally.
And so those are the things I think very often that lead psychiatry to being involved. And in fact, there's only one study that I know of in the entire literature on this. It's a really nice study a few years ago when it kind of looked at kind of what is the breakdown between when neurology gets consulted for delirium and the delirium spectrum conditions, acute encephalopathy, what have you. And then when psychiatry does, psychiatrists were much more likely to prescribe or recommend prescribing medications. Neurologists were much more likely to recommend workup, be it, an LP, brain imaging, things like that. And I think there's probably an upstream reason for that. So I think psychiatrists usually get involved when there's a lot of behavioral complexity and neuropsychiatric complexity, intuitively. And neurologists get consulted when the person, let's say, doesn't have necessarily, but they could, not necessarily the same behavioral complexity, but there is a diagnostic complexity or kind of lack of clarity. And so the neurology team comes by and they do their neurological workup, their neurological assessment, what have you. And so I think it just naturally works out that way, but that might just be an artifact of kind of recognition and the way that things present.
That is an absolutely brilliant take on that. And I initially I was thinking, well, we're all hammers looking for nails, aren't we? But it's way more complex than that. And I think that you're being You're giving everybody a lot more credit than that. You're saying that the nails, the hardware with which we get presented is very different based upon the specialty that we're practicing in. So it would make sense in a way that our approach would be very different because the substrate is very different.
I agree. Now, I'm also going to say it's probably both and.
Yeah.
So yes. So I think the upstream effects really do factor into who gets consulted and what those recommendations are, because the recommendations should reasonably meet the consult question. But I completely agree with you that if you have a hammer, everything is a nail. And so perhaps, and I mean, I don't know of any empirical data on this, but perhaps psychiatrists are more likely to recommend psychotropics, um, non-beneficial psychotropics than other specialties. And maybe neurology is liable to recommend non-beneficial workup more than other specialties. I don't know if that's true, but it's certainly plausible that that could play a role as well.
Great thought food there. Okay, so often I've heard delirium described to patients or to patients' families as it's a sign that a patient's medical illness is significant enough that their brain, their central nervous system is no longer able to maintain proper balance. That is, homeostasis is disrupted in the central nervous system due to some organic insult. But could we be more specific here about what that organic insult is? Do we know anything for sure about the neuropathophysiology of delirium? What neurotransmitter systems are involved? Any circuits that we should be aware of? Is there any settled science in this area?
So I think the science is becoming settled regarding the final common pathway. What is less settled is this idea that there are perhaps many different physiological pathways to achieve that final common pathway. And so the final common pathway currently is kind of understood as systems failure. So essentially, there are we talk in terms of networks in the brain that subserve kind of these complex functions. So the default mode network has got a lot of press the last couple of decades. And this network is involved in kind of self reflection, internal focused cognition. And you're not doing anything, but your mind is active and you're thinking and you have internal narrative, things like that. And so that's again internally focused, and you're not actively, consciously doing other activities. Then you have kind of this, broadly speaking, and there are a couple of different networks that kind of fit into this, but broadly a cognitive executive network, or in other literature, a task positive or a task on network. So that when you are actively doing something, that network turns on. So if you're doing something that requires attention or focus, or you're doing mental math or things like that, problem solving, that network is on and the default mode network turns off. And so these are supposed to be anti-correlated, which is to say that it's a switch. One turns on, the other turns off, and vice versa. And then you have something kind of right in the kind of the central prefrontal cortex, kind of into the anterior cingulate, that involves what's called the salience network. So things that are salient in the environment, or even things internally that are salient. And the salience network is involved in that flip flop switch, turning the default mode network off and the task positive network on, and vice versa. Now, in health, it should be one or the other, and the salience network should kind of sit at the middle and say, okay, now we're going to pay attention to this. Now we don't have to. Now let's kind of turn inwardly and relax. We're not focused on something outside. In delirium, that anti-correlation of the default mode network and the cognitive executive network is disrupted, such that you get kind of a bleeding in of both internal and externally focused things, and the salience network is not arbitrating appropriately between the two. And just imagine if you couldn't focus on one thing when you wanted to, well, what would you have? Well, you'd have inattention, and you wouldn't be aware of your surroundings, and you wouldn't have appropriate salience, and things wouldn't make sense. So, at a final common pathway level, again, we think that these two networks are not appropriately organized by way of the salient network. Now, the questions that I find particularly fascinating pertain to kind of thinking about delirium not as one thing, but as many things. So, delirium represents the convergence of many different physiological disturbances, right? So, you could get there by way of alcohol withdrawal, DTs, delirium tremens, alcohol withdrawal delirium. And that is a state of hyperglutamatergic activity. So your glutamate is on, your NMDA receptors are active, and it's a time of increased excitatory tone. And we treat that with benzos. So yes, we do treat some delirium with benzos. But then there are other deliria that come by way of oxidative stress, or maybe they come by way of an intoxicant like, an anticholinergic toxidrome. Um, and so I think you can get there by many different pathways, but ultimately, all of the pathways, and it's a fascinating thing, they tend to converge at this thing that we call delirium, where physiologically these brain networks are no longer appropriately coordinated for internal and external task positive, task negative networks in terms of in terms of activity.
You have an absolutely amazing way to break down very, very complicated topics in ways that are very easy to understand. I think that's very, very clear for our listeners. Is there anything you want to add with regard to the neurotransmitter systems?
Yeah, I think maybe one other thing I might mention is the idea of I wrote this in something online recently, more as kind of a thought piece, but I think a lot of people, when they look at delirium, they think of it as something to be avoided, something to be, how should I say, eliminated. And by the way, I'm against delirium. I'm anti-delirium. I don't think we should have more delirium. But I do think that delirium deserves its due for its value in telling us something about what's happening underneath the hood. And what I mean by that is I think of this analogy of like the blue screen of death, right? So when you're on Windows and the operating system crashes and you get a blue screen of death, the blue screen of death is not the enemy. Like like they could have coded Windows differently without a blue screen of death, but it would not have made the system any more stable, right? So the fact that we have something like delirium that is an index is, I think, in some ways more of a feature than a bug in the system. And similarly, we can think about, starting a computer and turning it in like after the blue screen of death, and you go into like safe mode. Like safe mode is not the problem. It's good that you can turn your computer on and access core features so that you can do the work you need to do and then turn it off and on again and poof, things reset. That's like sleep. I think sleep in some ways resets the brain. Have you tried turning it off and on again? So a really healthy physiological sleep can help. So the physiology of delirium is in itself, I don't think the problem, but it's an index. And so maybe if we reconceptualize delirium a little bit, we may kind of have a rapprochement with delirium as a concept as we begin to kind of make inroads into understanding some of the nuance of the condition.
Right. It serves an important function for us clinically, as doctors to know, hey, there's some disruption to homeostasis that we need to figure out soon. But also, it makes you wonder evolutionarily, how was it helpful for us? That's a really interesting concept. Okay, so the $1,000,000 question here, and you've alluded to it somewhat. How do we treat delirium?
Yeah. So I think in this regard, I'll dispense with the idea that antipsychotics cure delirium. We can dispense with that pretty easily. Delirium is not Haldol-apnea. It's not a deficiency of antipsychotics. Um, but I guess in a way, I'm kind of going back to some of the things I've already said, but perhaps extending upon that. You know, uh, our model of delirium, how we understand the broader diagnostic construct, should guide a rational approach to delirium treatment. So the model of delirium that I've talked about, it's not widely accepted as a model, but it's something that I'm kind of trying to advocate a bit more for, just largely so that we think more comprehensively about the different kind of levers that we can pull for delirium and clinically manage it in a comprehensive fashion. I think of it as having four elements. So you have the proximal precipitant or precipitants, so all the things that caused delirium. Then you have the downstream pathophysiology. Some of it might be inflammatory, some of it might be anticholinergic toxidrome, some of it might be excitatory excess with glutamate and the like. And then you have the clinical phenotype itself, delirium, plus minus neuropsychiatric disturbances. So those are the three canonical pieces of delirium, at least as I think about it. And then you have all these other factors for cognitive health. So we could say that these are kind of, they promote cognitive health, they're pro-cognitive in that regard, or we could say that this is cognitive or physiological resilience or cognitive reserve. And so that might be another area. So when we come to the patient who has delirium or is at risk for delirium, you can think about prevention in a moment, but when the person has delirium, we need to shore up all of these pro-cognitive factors that will inform the broader kind of patient in context. So that includes things like cognitive stimulation, engagement with people around them, getting up and walking so that they don't become deconditioned, making sure that they have their glasses and their dentures and their hearing aids if needed. Like that's, by the way, I don't even consider that treatment. That's just like good humanistic care. Like it's not treating delirium, but we should be doing these things. But if we want to put them under the banner of treatment, so be it. Fair by me, as long as we do it. So that's kind of treating these contributors to delirium. Next, we treat the underlying cause or causes. Very often there's more than one, but sometimes, there's just that one. So it could be sepsis, or it could be, the person has acute kidney injury, something like that, right? So you treat the underlying cause. I'm going to skip the pathophysiology for just a moment and come down to treating delirium, the clinical phenotype. And that is, we don't have great, again, delirium specific treatments. But when we really begin to think about psychopharmacology, and we can unpack this in a moment, the psychopharm that we're using is not for delirium proper, it's for discrete neuropsychiatric disturbances. So if the person is distressed, if they are paranoid, if they are agitated, if they are, if they have akathisia, right? All of those things, those are the clinical syndromes, the clinical symptoms, clinical signs that we are addressing by way of psychopharmacology and also non-pharm treatments to shore up a sense of safety, engagement, family involvement, those kinds of things. So we can manage delirium at that level. And then finally, getting back to the pathophysiology, I think this is the area that's most interesting for the current delirium research space. And that is really beginning to unpack what those physiological disturbances are. Because that really is, I think, should be the future of delirium research, understanding the different subtypes, physiologically speaking, of delirium. Because it may well be that a lot of people with delirium could be treated with things like physostigmine or cholinesterase inhibitors. Maybe there's a subgroup of individuals that preferentially will be improved. Their symptoms will be improved with that intervention. Maybe there are individuals who have a dopaminergic excess and antipsychotics that block D2 are specifically, uniquely effective. We know that somebody who has valproic acid associated hyperammonemia, we can use levocarnitine. It just kind of jump starts the ammonia breakdown, and so it reduces ammonia. So again, if we understand these physiological intermediate states between the proximal cause and the phenotype, I think that offers us a great deal of insight and offers us novel treatment targets to move the field forward and to begin to surgically kind of cut these out and identify them as codified biologically defined delirium states.
And I think that conversation speaks to why we don't have a single agent or a series of agents that actually treat delirium. And it's because of the reality, which is these are multiple different physiological phenomena which are manifesting as delirium. And so to think that we would have one cure for all of these various disruptions of homeostasis is a little bit silly after all. So you're suggesting we definitely work up and treat the underlying cause to promote overall brain health, things like sleep, making sure that the person has all of their sensory modalities functioning as well as can be possible, nutrition, mobility, etc. And then targeting specific, I believe you said neurophysiological sequela, which to me sounds a little bit like symptoms if we have a targeted treatment.
Oh, so neuropsychiatric disturbances.
Neuropsychiatric disturbances.
Neuropsychiatric, yeah, yeah. So I mean, so when we think about dementia, right? So there's the behavioral and psychological symptoms of dementia. And then one other way of saying that is the neuropsychiatric symptoms of dementia. I don't like the word symptom because symptom doesn't actually technically include symptoms are subjective, usually, if you want to be kind of a purist on the word. So I want it to be broader in encompassing not only symptoms but signs, and that includes behaviors. And so disturbances, I think, is a broader construct. So that's why I use the word neuropsychiatric disturbances, because it encompasses the internal experiences, symptoms, the distress, the paranoia, things like that, but it also includes the behavioral disturbances and the other kind of clinical manifestations that are objectively evident when you're engaging with that patient. So that's why I use that term.
Gotcha. Thank you for being granular with us. I think that's going to be really, really helpful and enlightening to our learners, especially our learners in training like myself. Any other specific strategies you want to recommend in terms of optimizing brain function?
So, I think, yeah, I guess my only answer to that would be what we've already talked about, which is the idea of things that promote brain health. I mean, there are what we call broadly delirium bundles. So that's a term in the literature, a term of art, delirium bundles. So that they're effectively kind of codified sets of brain health promoting, not usually non-pharm interventions that again promote healthy cognition, socialization, good sleep, things like that. And so perhaps two of the better known ones of these, and they're actually broader than just delirium bundles, would be the HELP model, so Hospital Elder Life Program. This is very often heavily volunteer and nursing based interventions that promote elder health in the hospital. And one of the major benefits is by reducing the rates of delirium, also preventing things like falls and deconditioning, things like that. And then generally on geriatric floors or other hospital medicine type floors. And then in the ICU, the kind of the broader bundle is called the A to F bundle. So sometimes abbreviated A, the letter A, the number two, the letter F, which is cute and simple. So I like that. And I'm just waiting. I'm genuinely waiting for them to get to Z because like they'll get to Z. Just give them time. I have every faith that we'll get to Z, A to Z. But essentially, these are things that focus on limiting potentially deliriogenic medications, spontaneous awakening, spontaneous breathing trials. That's the kind of the A and B kind of idea in there, choice of sedation, and then kind of going all the way to F, family engagement, family involvement. And so I think, again, these are things that support, but not only brain health. I mean, these have a panoply of benefits that go beyond brain health. So on the one hand, yes, they are cognitively beneficial, but they also provide, I think, kind of systemic benefits and recovery focused, dispositionally focused or dispositionally minded benefits as well.
As someone who had not spent a whole lot of time in hospitals until starting medical training, it was surprising to me, and even now still a little bit, that they're not always, it seems, places of health in some ways. They're places where we work up, identify, treat acute diseases, but not always terribly, globally speaking, healthful for our patients while they're there. And I think that navigating these systems, making these systems more healthy can be really tough, really daunting for a trainee, especially like a resident. And in ensuring adequate treatment for our patients who have delirium, a lot of this goes beyond medicine. It's more advocacy, how to work well in the hospital, how to play well on a team. You alluded to some of this earlier. Just want to know from your hard won wisdom, any like rock hard tips about how a resident can be a good advocate for their patient in this way?
Yeah, so I'm going to echo something you just said, which is that, and I say that I have a love-hate relationship with hospitals. I work in hospitals, I do research in hospitals, so I totally appreciate the dynamics of the hospital setting, and it really is something of almost a miracle, the kinds of things that modern medical science can achieve these days. But hospitals are the worst place for sick patients to be. We want to be able to discharge people home as soon as possible. The longer people are in the hospital, it's just an environment with so many potential perils. So totally appreciate that. In terms of advocating for patients, I guess it really depends on how ambitious the resident or trainee might want to be. So for instance, I mean, on the one hand, at a very direct patient care level, providing education is really important. Providing hands-on education to other trainees who might be younger than them, and so that helps consolidate their own knowledge. Providing meaningful education to the person consulting them if they're, again, working in a medical surgical setting. Providing hands-on care to a kind of teaching training to the nurses who happen to be at the bedside and asking them about, what they've observed, how they've been doing it, and then maybe even the nurse to go with them, asking the medical team to go with them if they happen to be right outside the room or on the unit, the nursing station, and say, let's go see this person together real quick. I just want to confirm what we're talking about, what I'm seeing. And so maybe we can compare notes and see how people are doing, because very often we're using words in psychiatry that maybe other people aren't using the same way. So when we say that the person's not paying attention and the medical team is saying, well, they answered my question, they clearly are paying attention. Well, we're saying they don't pay attention. We mean they can't, let's say, sustain attention. And we're doing a task to show it. So I think that's kind of hands on a one-on-one or small group kinds of education. Higher level than that, one might think about doing educational initiatives, so providing kind of in services or providing education, so doing different noon seminars and asking to be able to present in different forums to our colleagues to provide a shared language, to provide kind of just in the spirit of education, just sharing clinical pearls about evaluation, management, and so forth. And then we could elevate this one step further, but again, this is where I'm saying, like, how ambitious does the resident want to be? When you're really getting at systemic change in a hospital, it's tough. So when you want to change the electronic medical record, you can't just change it usually in one unit. If you're going to make a change, it's gonna have to be signed off on at a much higher level. So if you really wanna add, oh, let's say we're using this instrument and it's not really working out and you wanna change to a different instrument, that's gonna take a bit of work. Or if you wanna do a delirium order set, or if you wanna do a delirium list, or if you wanna kind of promote delirium on the story page of your electronic medical record, the login, what have you. These are kind of some of the kind of implementation things that we've kind of done at our institution at the University of Rochester. And again, I think they really advance and enhance care, but they are longer term engagements and they require sustained advocacy over a period of time and really networking with people across the institution outside of psychiatry, because delirium affects everyone. Delirium affects every specialty. It affects all the different clinicians and disciplines. So in that regard, it depends on how much energy and time and advocacy a person really is able practically to invest.
No, that's very practical for us, and it's not a sprint. It's probably more of a marathon to change hospitals. But also, you reminded us that education is power. Education can be very helpful for our patients by educating family, by helping to educate staff, by spreading the good news. I think where the rubber hits the road, you can really help your patient out. Okay, so pharmacology of delirium strikes me as a particularly sort of, I don't know if controversial is the word, but definitely intriguing area. We've teased it a little bit. We've made fun of what may be a very helpful agent, as a matter of fact. What does the evidence tell us about pharmacologic management of delirium?
What do I wish it showed us that is very different from what it does show us? So historically, the pharmacological treatments of delirium have treated delirium as all-cause delirium. And the question is, can we find a medication that is an antidote to delirium? That's how it's been approached. And I'd like to come back to this idea of all-cause delirium a little bit later, but what we have found is that if you block a whole bunch of D2 receptors, arguably the majority of them, that does not cure delirium. And I'll just cite the Mind USA study. It was a great ICU study that investigated the use of haloperidol and ziprasidone, pretty assertively dosed, by the way, agents for the management of delirium in the ICU. And lo and behold, haloperidol and ziprasidone did not cure delirium. So we know that by just blocking more D2 receptors, we have not ipso facto reversed delirium. So what do we know? Delirium is not inherently a state exclusively of too much dopamine, and if you block enough of it, you reverse it. But that doesn't answer the questions that I think we all really want to know, which is, well, if a person is agitated with delirium, so we'll say hyperactive delirium, which is hyperactive is just a descriptor of too much activity. It doesn't mean anything necessarily intrinsically, but a person who is hyperactive, agitated, activated, and has delirium, I think what we want to know is if we use a medication to treat this, will we improve the hyperactivity, agitation, what have you, better than if we had just done nothing or placebo? And in fact, there was an interesting study a few years ago where this was in a palliative care kind of oncology setting. It was published in JAMA. And essentially, this study found that it enrolled people with hyperactive delirium, and they were given haloperidol in a scheduled fashion for 48 hours as kind of a run-in. And anybody who still had hyperactivity at roughly 48 hours, I believe it was, were randomized to receive either 3 milligrams of lorazepam or placebo. And the question was, which of these agents, or did lorazepam in an otherwise benzo-naive individual, 3 milligrams, a pretty substantial dose, did that improve the hyperactivity in these patients better than placebo? And it was an 8-hour follow-out study, and they tracked the RAS over the course of 8 hours. And they found that lorazepam slightly, a little bit faster than placebo, helped put people to sleep. But when you look at the average RAS, most people were pretty much asleep. But when you look at the kind of the placebo group, I think this is the more instructive and interesting finding. Their average RAS was between 0 and -1 within about an hour or so. And our target RAS in the ICU is usually 0 to -1, not asleep. And so I think very often when we give agents to patients and we think, oh, look, now they got less activated, we attribute the change to our intervention. But sometimes, as this study I think shows pretty nicely, if we had done nothing, the natural course of this outlying clinical phenotype of hyperactivity would have been to regress to the normal. We were not sufficiently regressive in our projections effectively. And so I'd say be a little cautious about overinterpreting the kind of clinical outcome based on what we gave the patient. So that's really a question of attribution. But what do we know about different phenotypes of delirium, and what might medications do? Now, I'm going to go beyond the current evidence and just kind of map out perhaps a few things that I'd like to know and some clinical tips that I know I've heard from a number of colleagues around the country about how we might think about this and what agents might be thought of. So if a person has agitation, antipsychotics are to date really the agent of choice in most deliria. Haloperidol can be beneficial over a number of other agents simply because it has multiple routes of administration, including IV, and it doesn't have any anticholinergic properties really to speak of. So in that regard, you're not theoretically worsening the cholinergic deficit if that happens to be playing a role in that patient's presentation. At the same time, Quetiapine, olanzapine, risperidone, other atypicals may be considered in certain patients. They have perhaps a little better mood regulation properties. We think about them in bipolar disorder. And so maybe applying that to an individual who has those same symptoms in delirium might be appropriate. We know that all three of those agents, olanzapine, quetiapine, risperidone, are sedating. And so it's not uncommon to give a higher dose of those agents in the evening before bedtime to help facilitate healthier, more physiologically restorative sleep. And so, again, that's a common practice. And somebody has perceptual disturbances, certainly an antipsychotic might be considered in that context to treat the psychotic symptom. Although I'll just throw out there, maybe it's not D2, maybe it's more serotonergic. So we think about pimavanserin as a serotonin 2A inverse agonist to treat hallucinations in Parkinson's disease. It's not an anti-D2 agent. And yet somehow it could well be that serotonin 2A and other serotonin receptors play a role. Again, an unexplored area, an interesting question, but we do know that a number of the atypicals block serotonin 2A. So maybe there is some added benefit for atypicals in managing psychotic symptoms or perceptual disturbances in delirium. Again, kind of just thinking about what we know in other contexts. But then beyond antipsychotics, right, there are a number of other agents that might be considered. I've already mentioned earlier, benzodiazepines are used to treat alcohol withdrawal delirium. Benzodiazepines may be used in other states like anti-NMDA receptor antibody encephalitis, serotonin syndrome, NMS, neuroleptic malignant syndrome. So benzos may be reasonably appropriate in those contexts, or other delirium that happens to present with catatonic symptoms, maybe a lower dose of a benzodiazepine. Beyond kind of the two that we always talk about, benzos or antipsychotics, we could get to alpha-2 agonists. So dexmedetomidine is an IV infusion. It's a sedative, but it's not GABAergic. We know that dexmedetomidine can prevent delirium in the ICU, even when given lower dose at night relative to placebo. We know that it really tamps down on some of the sympathetic activity, the activation physiologically, so it can be beneficial to manage some of the agitation in delirium, provided it's medically appropriate, thinking about vital signs and so forth. As a result of that, some people have begun to explore the use of things like guanfacine and clonidine, which are oral agents, guanfacine with less of an effect on blood pressure than clonidine. Clonidine, though, can be given as a patch, which is an interesting opportunity here. And then beyond those, I mean, it's an interesting and open slate of other psychopharmacology. Gabapentin or gabapentinoids could be used for akathisia and restlessness. So again, if someone's constantly moving, we might think about using something like a beta blocker, propranolol, a non-selective a beta blocker for akathisia, again, gabapentinoids, things like that. Let's see. And then I think I guess one other flip side of this is, what if the person has delirium and they're hypoactive and they're not engaged? Is psychopharmacology relevant there? And I would say that it can be helpful, kind of speaking clinically, anecdotally, but not a lot of great data yet. Things like modafinil, armodafinil are kind of non-stimulant wake promoting agents that could be given in the morning to help people stay awake during the day, which helps them consolidate sleep the next night. Stimulants might be considered low dose, definitely not getting much past, let's say, noon, 1 o'clock, because you don't want to keep them up the next night. But stimulants can be helpful to engage people to combat the abulia, the inanition, the lack of engagement, to help people ambulate, to be engaged cognitively, socially. Certainly caution about cardiac status, also caution if somebody has perceptual disturbances or psychotic symptoms. Obviously, stimulants can make that worse. Again, I'm just kind of painting a picture of a variety of other psychopharmacological interventions that might be reasonable in selected patients, considering risk-benefit ratio. What exactly are we treating? What do we want to achieve? And how can we help facilitate recovery in this patient, again, based on the neuropsychiatric disturbances that they have?
So no treatment necessarily indicated for the delirium itself, but depending on the full clinical picture, there may be some reasonable options for specific neuropsychiatric disturbances that you want to target. Is that right?
Yeah, exactly. That's how I clinically approach it. And I think, it's interesting. I mean, if we go back maybe 10 years, 20 years in the literature, I'm not so sure that that was as common a way of talking about it. I mean, but I do, and again, I'm kind of drawing an analogy from the way that we think about dementia. So the last, couple of decades in the dementia literature has really begun to articulate what are the neuropsychiatric symptoms, neuropsychiatric disturbances of dementia. And how do we best kind of, one, define them, but two, how do we treat them? And which of them is more common in which type, kind of pathologically speaking, of dementia? So Parkinson disease or dementia with Lewy bodies or Alzheimer disease, frontotemporal dementia. And so a lot of the work has really been kind of pairing underlying neuropathology with discrete neuropsychiatric syndromes and neuropsychiatric disturbances. And I think that kind of approach, I think the dementia literature is like decades ahead of the delirium literature. Right now, we're just talking about all-cause delirium. Dementia used to be all-cause dementia. Now, when you say all-cause dementia, in fact, that feels like we're going backward, right? We're increasingly wanting to specify not only that it's Alzheimer type, but now we're talking about specific kind of taxonomies of Alzheimer disease based on whether it has certain, CSF findings or imaging findings and the like. And so as we grow in specification in Alzheimer disease and related dementias, that kind of specification, I think, should also apply in its own way, physiologically speaking, to the delirium field. And then superimposed on top of that are these neuropsychiatric disturbances. And I think targeting these unique disturbances could be a very clinically actionable and a way to get traction in an area that we have really wanted for traction, really since time immemorial.
You're giving us a really exciting look into kind of the future of psychiatry. So I'll be doing consults next year when I start my life as an attending, and hopefully for well, who knows, for a long time, hopefully for most of my career. And it's like I'm getting a little window into what I might be using in the future, what might be available to me, what the evidence might say. So it's definitely something to get excited about. I want to walk through what I think is a relatively common clinical scenario and just kind of get your thoughts on it. So let's say we have a patient who presents with confusion, etc. And I'm basically trying to paint a very straightforward delirium case, right? So this is an older patient. They present with delirium. We find that they have a lower urinary tract infection. We treat it. Now it's 24 hours later, and the patient is still delirious. What do we do here? Do we wait for the delirium to resolve? Will the delirium just resolve since we've treated the presumed culprit for the kind of underlying cause? Or do we do further investigation? Do we treat symptomatically? How would you recommend approaching this patient?
So first off, there are some who would dispute, not a lot, but some would dispute whether urinary tract infections cause delirium.
Wow.
So I have heard that as a perspective. The other interesting question here, and this is an empirical or epistemic question, is, we talk about asymptomatic bacteriuria. A person with delirium is not going to report their symptoms very well. So do you have burning? Do you have, I don't know. Maybe they're really confused and they can't give you that information. So again, it ends up being an epistemic question. How do you know whether they are asymptomatic? You know they have bacteriuria. Maybe they have white blood cells, leukoesterase, and what have you in the urine. Is this a real UTI? So that's an interesting question. So I'll add that level of complication here. At the same time, this is so common. So some people are going to say, well, you treated the UTI, or what you presumed was a UTI. Empirically, you treated it, and they didn't get better. See, it wasn't the UTI. UTIs don't cause delirium. One question might be, though, why do people not get better after the proximal precipitant is out of the picture, right? So I think that's the question we have here. And watchful waiting is unfortunately very often I don't know, the treatment du jour, right? That's what people do. But if I'm going to kind of recall the three parts, kind of the tripartite model of delirium, the disorder, a moment ago, right? So we have the proximal cause, you have the intervening physiology, and then you have the clinical phenotype. So now we've knocked out the top thing. We've knocked out the thing up top, the upstream cause. The pathophysiology doesn't necessarily reverse immediately. So it could well be that although the bacterium is gone, the inflammation is still present, right? So the inflammation peripherally could still be present. There is a condition called cystocerebral syndrome, which might not necessarily be this, but when you have bladder distension, it sends a sympathetic message up kind of afferently to the CNS, and that itself can cause delirium. And as soon as you decompress the bladder, it goes away. The confusion goes away usually within minutes. I've seen it melt away when a person has urinary tract, we'll say retention, so bladder distension due to urinary retention. Once you decompress it's very often an irritable delirium. That goes away very often, can melt away. So it could be that the person is still retaining urine. That could be another contributor. But really, I mean, I would be, at this point, if the person's still confused, I think this is where the future of delirium and whether anti-inflammatories might be the appropriate treatment. I don't know the answer to that, but again, I want to paint a picture that says the pathophysiology is clearly still relevant because the person isn't clear-minded yet. How do we facilitate healthy cognition in this person? At the same time, if they remain really delirious, I think the clinical answer is also probably broaden the net, make sure they don't have other causes. Maybe it was actually urosepsis, and so maybe it actually is more impactful than we had originally realized. Maybe there are other issues as to why. Maybe through the delirium, they became dehydrated and now they have hypernatremia because they haven't been drinking as much free water. And so now we're getting into the physiology and how well they're taking care of themselves and whether we can support them metabolically, physiologically, functionally while we work with them toward recovery.
Okay, so having respect for the fact that just because we think we have a culprit, we may need to cast a wider net, look at it a little bit more deeply. And also, just because we've theoretically corrected the underlying cause, all of the pathophysiological manifestations of whatever that culprit is are likely ongoing and will likely require some time to improve. And as you mentioned before, some people never do return to their prior cognitive baseline. Is that right?
That's true. And another analogy which I think is very clear as a kind of, the proximal precipitant is in the past, post-operative delirium, right? So there is anesthesia and then there is the tissue injury that occurs at the time of surgery. So there's an inflammatory response. The body's going to try to heal itself. It will be an inflammatory response after surgery. It's not an unhealthy thing, but in some individuals, it leads to delirium. We know that postoperative delirium tends to peak in phase with the elevation in C-reactive protein. So when C-reactive protein goes up, delirium goes up, and it parallels that peak, temporally coincident with the peak in general. Now, of course, it can be a little bit dissociated, but that's the general finding. And so think about postoperative delirium. The cause is always in the past, but the physiology is in the present. And so you can't go back in time and make it so that the person didn't have the surgery. You can't go back in time and make it so that the person did not have the UTI or whatever the proximal thing is. But the thing that persists, that is perhaps mediating or catalyzing or keeping the delirium clinical phenotype alive, is still active. And so, again, this is where I think differentiating the proximal precipitant and the downstream pathophysiology, the broader encephalopathy, is important and helpful because it could provide novel insights in future studies and future clinical care to address the thing that is keeping it alive. And I'm just going to say, because I love sleep, kind of sleep research in relation to delirium, maybe it's simply that they need a really healthy, healthful night of sleep. It's like in IT. Have you tried turning it off and on again? So we got to turn it off, but you can't just turn it off in delirium. Delirium is not sleep. It's really a disturbed global cognitive state. But sleep should have certain kind of phases. You progress through different phases. You have certain discrete REM episodes, right? So, in that sense, maybe it's simply that we need also to do these kinds of restorative physiological interventions that facilitate healthy cognition.
You're giving me flashbacks to being a third year medical student and waking patients up at 4:30 a.m. on pre-rounds, 5 a.m. on pre-rounds, and thinking, I just don't know how helpful this is for your healing. So I feel for you, to all of our students listening. I don't know what to tell you, but I empathize with you. I've been there, and I guess just do your best. And that's an amazing nugget about the CRP and the delirium. I had not heard that before, and I think you're just sort of showing us a little glimpse of what you think the future might hold.
Absolutely. Yeah. Again, if we dial into the pathophysiology, I feel like that's going to be kind of it's currently an unexplored area, but I think there's a lot of optimism currently to think that, maybe we can dissect out, again, different physiological subtypes of delirium.
Who overall is most at risk for delirium?
Because, and I'm going to say this kind of in the context of what we already talked about, we know about the final common pathway of delirium being a network dysfunction or kind of dysregulation failure. It would be presumably the people who have the least reserve of those cognitive networks and those who have the least agile networks. And so what would we find? We would expect people to have who are older, who have a greater risk of delirium. I already alluded to the fact that they happen to have a higher risk of delirium overall. Number two, people who have baseline cognitive impairment. So this already speaks to kind of they're starting out kind of one rung down in terms of the cognitive coherence of the different networks in their temporal sequencing and the ability to process information clearly and remain abreast of salience in their environment. Third, people who have functional impairment as a whole tend to have greater risk of delirium, and it may well be that these are individuals who have higher frailty. There are a number of ways of measuring frailty, but higher frailty and functional impairment would predict greater risk of delirium. And two other notable populations, one would be people who have greater severity or complexity or acuity of illness itself. So, if someone has a much more severe sepsis, then they're much more likely to develop delirium versus somebody who has bacteremia, but not that sepsis response. So, right, it's the severity of the inflammation, it's the severity of the oxidative insult, it's the severity of the thing that, again, is disrupting the neurotransmitters as a whole and drawing metabolic demands away from something like the higher cortical functioning of the brain. And then the other population that I'll think about are those individuals with polypharmacy or hyper polypharmacy. There are a lot of people with a lot, and I mean a lot of medications. And, on the one hand, we think about basic things like, the Beers criteria. So they updated those in 2023, the 2023 AGS or American Geriatric Society Beers criteria. And so this is identifying potentially inappropriate medications in older adults. And a variety of those are on the Beers criteria list because they can cause delirium. But on the one hand, yes, so some of them are anticholinergic, some of them are, opioids, some of them in other ways impair cognition. But when you get a lot of medications, the likelihood of drug interactions increases exponentially. And I'm not sure that a lot of us, and I'm going to include myself in this bucket, are really aware of all the many potential drug interactions that happen. When you get to 10, 12, 15, 20 medications, the likelihood that one of these interacts with another one of them is so high. And then again, when you see people with these long lists of medications, these laundry lists of medications, these are usually in older adults who are already more frail and already have some degree of functional impairment and may also have some degree of baseline cognitive impairment. And so we're really adding insult to injury at times when this long list of medications, again, conspires against the patient at times. And so deprescribing might be the appropriate approach. And there's a lot of push right now to do deprescribing initiatives. Do they really need these medications? What are we actually aiming to achieve by providing all these medications? And could we be doing more harm at times than we're actually aiming to do for good?
I love it. We may have to do a whole episode on psychiatric deprescribing. So you're coming through the list of polypharmacy, you're using the Beers criteria, you're getting to a more rational medication regimen. There are some kind of non-modifiable risk factors, advanced age, maybe things like cognitive impairment that you can't modify. You're promoting overall good brain health, things like mobility, sleep, etc. We've talked about that. Any other nuggets about preventing delirium that you think is important for our learners to know?
So I'll say this. There was a recent Cochrane review, which I think is really important to note, that about 40% of delirium, up to 40% of delirium, is preventable in cognitively at-risk populations. This is a Cochrane review. I believe it was published in 2021. And I mean, I think that's an important consideration. I think this is one of the big things we've learned over the last, let's say, 15, 20 years, that delirium is in fact preventable when you use these things like delirium bundles, help, A to F bundle, things like that. So preventing delirium is possible and should be front and center. Um, One thing we don't know is whether these bundles hasten the resolution of delirium. So there are no good studies where we can say, oh, if you weren't doing those things before, but now the person has delirium, if you do the non-pharm now, we're going to get it better faster. Now, of course, it would almost be kind of unethical not to give the preventive treatment and then to just give it right once the delirium starts. One could argue maybe we have equipoise, and based on equipoise, we could say, we want to really allocate our resources more in a more targeted fashion. But we don't know yet whether those kinds of things hasten the resolution of delirium when it happens. But I'll push, I guess, into the future of delirium. You say, what about preventing delirium? I'm really curious about pharmacological prevention as well. So I mentioned a moment ago, dexmedetomidine can prevent delirium in certain models, especially in the ICU and specifically overnight. In one particular study I'm thinking about, Ioana Skrobic was the first author, and it was a two-site study, both in Boston and in Canada. And it again reduced the likelihood of delirium. Maybe it improved the physiologically restorative sleep at night. But there are other things that have been tried recently. There was a study, I think it was called the DEXA study, where basically acetaminophen was used postoperatively to prevent delirium. It was a kind of a four-way trial, so 2x2 and 2x2, and they had an across version. But essentially, the question is, can we prevent delirium by using other forms of analgesia? So that might be one thing to think about. There have been studies, they've not been positive. The largest one wasn't positive, but maybe using gabapentin in the postoperative setting as well to prevent, again, the larger study of that, to my knowledge, was not positive, but again, thinking creatively. There was one study published in the American Journal of Geriatric Psychiatry recently looking at intranasal that was positive in preventing postoperative delirium. And so the idea here is by improving glucose utilization in the brain, you improve cognition in the perioperative space. So the idea of insulin improves the uptake of glucose into cells, and so it's delivered intranasally. And so again, I'm really curious to know what future models and future paradigms of pharmacological prevention of delirium might look like as we understand with greater specificity the different physiological routes to delirium.
Wow, that's amazing. So many different So many different avenues of attack, it sounds like, as we kind of move forward. Okay, Dr. Oldham, open mic night. Any other common misunderstandings about delirium that you think are propagated, that you've kind of heard, that you want to correct to make sure that none of our Psychiatry Boot Camp listeners are propagating these misunderstandings?
Yeah. So we have another hour on this one, right?
Yes, of course.
No. So first off, I think the biggest misunderstanding is that delirium is one thing. So again, I said I'd come back to this later, but essentially, dementia historically was thought of as an all-cause dementia, and it was just you have dementia. Now we know there are many different we'll say neuropathologies that underlie dementia. And they are discrete, and they've really opened up our eyes to thinking about dementia in new and, I think, provocative ways and important ways. We wait for that to really fundamentally change care. Admittedly, it's not been an easy field to tackle, but it has given us a lot of insights into the fact that dementia is not one thing. It's many different things. So we can prognosticate a whole lot better when we know the underlying cause. Now, with delirium, again, we think of it in general. When we use the word delirium as a singular, delirium is, or what prevents delirium, or what predicts delirium, or what are the outcomes of delirium. We're using delirium in the singular, and without realizing it, we're actually implying all-cause delirium. And so again, I really want to, our language betrays us at times, and it makes it challenging, but I would say big misconception, delirium is one thing. We know it's not all one thing because alcohol withdrawal delirium is a thing. And we know that's very different. It's a very different thing from other delirium that we might articulate. Hepatic encephalopathy delirium, or delirium that presents as a result of, again, like we talked about earlier, UTI, sepsis, what have you. So I challenge the idea that's a one thing. Number two, I would challenge the idea that we should look for, or that we should expect, maybe we should continue looking for it, but that we should expect to find a one cause, a one size fits all treatment. I don't know. I mean, if we found it, good. I would love to be proven wrong. Please, someone prove me wrong. But the history of delirium scholarship increasingly suggests, and it suggests with increasing clarity, that we're really talking about many different things under the banner of delirium. So I don't know that we should expect to find one intervention that works for all delirium and all of its many kind of physiological subtypes, as well as all of its unique neuropsychiatric disturbances. A few other things I'll add for misconceptions, and I won't cover these in detail. There is we published a paper a couple of years ago on 10 delirium misconceptions. That the title is Responding to 10 Common Delirium Misconceptions with Best Evidence and Educational Review for Clinicians in 2017. So I would refer some of the listeners to check that out.
I'll put it in the notes.
So some of those, they're still relevant, and I think a lot of them are still misconceptions. So it bears repeating them. And then kind of getting to this idea of encephalopathy. A couple of misconceptions around delirium and encephalopathy that I'll add here at the end. One is that encephalopathy is a brain disease and delirium isn't. Again, I think that's a category error. Encephalopathy simply, by convention, describes the brain pathophysiology, whereas delirium, as a construct, includes both the clinical phenotype as well as the full spectrum of physiological kind of underpinnings that lead all the way from the proximal cause through the pathophysiology, namely the encephalopathy, all the way to the clinical phenotype. So again, delirium implies an underlying encephalopathy and includes it, whereas encephalopathy is restricted to the underlying pathobiology. And I'll end on this one, which is that this idea that encephalopathy is more severe than delirium. Again, I think at least even in our reimbursement models, metabolic and toxic encephalopathy are now currently designated as major complication or comorbidity, whereas delirium is not. And it strikes me as a bit strange because, again, conceptually, delirium implies underlying encephalopathy.
Wow.
And so it just seems to me that the two should be on par when we think about their magnitude of effect. And not only that, really the robust literature that surrounds delirium, rather that metabolic and toxic encephalopathy as generic categories really don't have their own unique literature that says metabolic encephalopathy is, and it predicts these outcomes, or these are the things that are risk factors for developing a metabolic encephalopathy. That's not the way the literature works. Literature clinically begins with the clinical presentation. And where do we begin? At the bedside. And at the bedside, what do we see? Encephalopathy? No. We see delirium. We take care of patients. I think the patient should be at the center of our care and at the center of our research. I think that's why, in general, I think I favor delirium and why it really captivates and it captivates me clinically, but why it matters.
It doesn't get much more concrete than that. You tracked it all the way down to the nitty and gritty of the reimbursement models. So thank you for sharing all that wisdom with us. You have been extraordinarily thorough and extraordinarily generous with me. Do you have any final thoughts for our listeners?
Yeah, I'll end on this. I wasn't expecting to have a final thought, but I'll add this as a coda. I've gotten into creating memes lately, and I would say, you have to add a level, you have to add a level of, just lightheartedness to the kinds of things that we do all day. And I think, humor is a healthy defense strategy. So I think channeling this into humor is wonderful. And so I don't know, just find ways of engaging with this in a spirited fashion that always defends the humanity of the patient and yourself and the family and what you do, the dignity of what you do. But you can absolutely and should absolutely engage even in things like this with a degree of levity and humor, because that's really important.
I love it. Use all the tools available to us to spread this message and hopefully in formats that people will actually use, like memes and maybe even a podcast.
Totally.
Thank you again for coming on, and I can't wait to talk to you next.
Thank you.
Thanks for listening to this episode of Psychiatry Boot Camp. Please leave a rating and review. If you have questions or feedback for me, you can email me at psychiatrybootcamppodcast@gmail.com. The opinions shared in this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete accredited psychiatry residency and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions and contact your physician for medical advice.